Now, our last session of the afternoon is upon us, Navigating the System, Global Advocacy Perspectives on Breaking Barriers to CLL Care. And I'm going to ask the panelists to come up as I introduce them as well. And this session will feature Professor John Seymour, who's a professor of medicine, University of Melbourne, and with the Department of Clinical Hematology at the Peter MacCallum Cancer Centre and Royal Melbourne Hospital. Joining Professor Seymour on stage will be Lise-lott Eriksson from Blood Cancer Forum, Sweden, and a longtime advocate and a chronic blood cancer patient as well. Lise-lott. And last, certainly not least, is Leila Uliza from Blood Cancer Foundation of Tanzania. And she is a hematology medical laboratory scientist and research project coordinator at the Department of Hematology and Blood Transfusion, MUHAS. Very good. Thank you very much to the three of you. And just a warning, depending on timing, we may lose Dr. Seymour here because he has another commitment, but we'll do our best to get through the session. So I will ask you to start if I can.
Thank you. Where do you want us to sit?
Do you have slides?
No.
No? Actually, come up here. Do either of you have slides? No. All right, so we'll put the chairs, you can go up there. We'll just put them in the middle of the stage and you can sit. Very good.
So first of all, thank you for the invitation to contribute and participate, and my personal and professional acknowledgement and support for the great work that you conduct and continue to do so. So my affirmation of the value for that. When I was asked to sort of speak around this, I wasn't quite sure what had been covered already, and the way I sort of consider or approach these issues really is in four categories, and as it meets your needs, happy to sort of then talk or respond to questions in each of those categories. First, and the one that often people think about, is sort of drugs, therapeutics. The second is really around technologies and diagnostics. The third is, I'd call it, professional structures. And then the fourth, that is very intimate to your own work, is really uplifting patient awareness, literacy, and their engagement in the process. And each of these, I feel, and in my experience, are iterative and can be self-supporting. So each of these domains can have a positive impact on each of the other domains. Of course, not in the pace that we would wish, and not always in a direct and recognizable fashion, but these are virtuously interacting processes. I'll just sort of give some general thoughts, and then I'm happy to respond to questions. At the drug level, again, I sort of approach this in a hierarchical sense. You know, there are many things that, yes, in the perfect world would be ideal to have, but again, a stepwise escalation from where are we currently, and you know, this issue of we are not at an optimal situation, I think applies to every single jurisdiction. You know, and that sort of hierarchy in my mind as a treating physician is, even at this point, enhancing the efficacy and safety of cytotoxic treatment. So for example, if chlorambucil is all that we have, then access to bendamustine is a significant step forward. And consistent access to a CD20 antibody, ideally obinutuzumab instead of rituximab. So even within those, let's call them historic or legacy platforms, there are capacity for improvement. Within targeted agents, I think the highest priority is access to a BTK inhibitor. I think then nuancing around which one is it, do you have a choice, etc., is finessing. And that's my personal approach, that hierarchical. And most of that is at a very high, be it national, be it regional, structural level, that we as individuals may not have direct capacity to influence, but of course, through our own advocacy, through our own emphasis, through our own recognition of priority. But some of the other elements that I'll speak about also have the ability to signal to other providers around structural maturity, capacity to ensure appropriate patient identification and designation, and also alternative other than governmental funded sources. And I'll come to that under professional structures and cooperative groups, collaborative structures, national networks, clinical trial groups are some of those examples that can provide conduits for those. At a technology or diagnostic level, again, I see a hierarchical approach. So the first is accuracy of diagnosis. Can we have certainty that this label that we're putting on a disease is truly what we believe it is? And that really comes down to consistent high quality flow cytometry in the first instance. Then there's increasing levels of sophistication to either determine prognostication or identify particular biologic subgroups that, again, depending on the country or region circumstances, you may wish to prioritize for access to newer drugs. And here, for example, the ability to recognize if our current standard of care treatment is cytotoxic chemotherapy, let's say bendamustine and a CD20 antibody, the ability to recognize TP53 aberrant disease is a definable group, a group with a high unmet need, a group that clearly does not have their needs met by existing therapies, and it's an encompassable and potentially achievable group to then achieve access to newer drugs. So that, again, sequential approach that might not be perfect, but again, it's incremental. At the professional structure levels in many of these areas, even designating, getting a group of like-minded and collaborative clinicians to share experience, to create a critical mass of interest, to designate a particular individual to then advocate for, reach out to other groups in terms of clinical trial participation, or even at the level of conference participation and bringing back knowledge, and then increasing levels of sophistication. That might then be a national society or a clinical trial network. And the fourth area around patient advocacy, that's, I certainly have, would be paternalistic of me to make any comments around that domain. But that's my personal sense of the sort of four areas of how do we approach and potentially break down barriers to access, and happy to take comments or questions and see how that interfaces with our other panel speakers. Thank you.
Yes. Considering where I come from, Sweden, we do have a lot of the structure around this is very much guidelines. There are guidelines for how patients should be treated. There are guidelines for how, with a very certain care driven, what should be done in different phases of the diagnosed. So from a CLL perspective, I think that the doctors in the group, we were very lucky to have a lot of clinical trials that actually show the benefit of the new agencies. So I think that we are very far up front with the new treatments for patients. But I would say that it isn't always the case that it's very equal, because the regions in Sweden, it's very much up to the regions and the hospital how they treat patients. Although we have those clinical guidelines that are supposed to be a way forward, that's not always the way how patients are treated, because there are restrictions in the budgets, and doctors, they are forced to, okay, you can't do this and this and this, depending on the budget restrictions. So, and I would also say that if we come to the first phase, which is also very important, how to get diagnosed, it's very much up to the general practitioners, because they have to make the referral to the hospitals. But when you are in the hospitals, it's very good. But the way before, and that is that system isn't that good in Sweden. And also when we come to the supportive care, that is something that isn't that good. And I know all these CLL patients, like we have been talking about today, you get to diagnose, but you shouldn't be treated. And you need someone actually to make that through to the patient, to explain why this is good, because this is good for the healthcare providers, but maybe not from a patient perspective. How should I get that point that, okay, this is good, I have leukemia, but I shouldn't be treated? How can that be good? So, and yeah, I think there are so much more than just the drugs and the treatments. And I wouldn't say that from a Swedish perspective is where we are so good and delivering to the patients.
Okay, thank you. I'm very honored to be here today representing the perspective from the lower and middle income countries. I think this conference, it's a great platform for all of us to learn from one another, share the unique challenges with each other are facing, and I'm going to share the perspective of the lower and middle income country. For example, countries like Tanzania, where I come from. The first barrier is limited access to diagnostic and specialists. In most lower and middle income country settings, the diagnostics like flow cytometry or molecular testing are scarce. So doctors have to rely into local specific tools. Even when the diagnosis is made, treatment is often unaffordable. And the only cancer centers are located in big cities. So this means for the rural families, they have to travel long distance, high cost. Others, they even sell their properties or abandon treatment altogether. The second barrier is high cost of treatment and limited availability of innovative therapies. Even when the patients are diagnosed, the medicine they need are often unaffordable. And the newer treatments remain out of reach. For many families, it means again selling their properties or abandoning treatment again. Third, the language and culture barriers, which they limit awareness and adherence. Many patients live with swollen lymph node, fatigue, fever for months. And before even thinking of seeing a specialist, in Tanzania, for example, someone might go from one clinic to another clinic being treated for infection until the disease is advanced. And our population doesn't know much about blood cancers, especially including the CLL. Even the patients who are treated from CLL, they'll just tell you they have blood cancers. Finally, the patient support system and psychological care are too weak. Too often, a diagnosis of cancer isolates a patient from their relatives and family to cope alone with the emotion and financial burden. But even with these barriers, we have already taken steps to address them as the Blood Cancer Foundation of Tanzania. So through the Blood Cancer Foundation of Tanzania, we have conducted community education sessions in different hospitals, like the Ocean Road Cancer Institute, which is the biggest cancer institute at the country, where we included the patients, families, and even nurses. They joined our discussion. Also, we have created the support network system that connect the patient. For instance, we just have the WhatsApp community, which include different types of cancer patients, including the CLL patients. So from there, they become one. Patients get hope from one another. And also, we have actively engaged the policymakers in the country, including we had a meeting with the Minister of Health and Minister of Policy of the country to advocate for improved access of diagnostics and medicines. And this meeting actually opened the doors to new conversation about integrating blood cancer services into national insurance and prioritizing them in policy agendas. So we are proud of it. But there are many strategies that we can use to break these barriers, such as educating them, simplifying diagnostic pathways by educating the primary health workers to recognize the CLL symptoms earlier before the disease advanced. And also we can expand policy advocacy so that the essential medicine are covered by insurance of our countries. And also we can scale awareness campaigns in local languages and culturally relevant formats. For example, we can translate patient information into simple, clear message, which will help to reach the wider community, especially the local communities. And also we can strengthen the community network. Imagine every regional hospital having a patient-led support group where newly diagnosed patient could immediately meet survivors and caregivers. This would transform isolation into strength. That's all for me. Thank you.
That's wonderful. Thank you. Are there questions from the floor for, I think I see a hand over here.
Hi, Deborah Henderson from Australia. I love this conference. It's always so humbling to hear the perspectives from other countries. I'm very fortunate. We're in a high-income country in Australia. In fact, Professor Seymour wrote our guidelines on CLL. Like Sweden, we do have a lot of inequity between regions and access to treatments and to specialists and timely diagnosis. But my question really is to you, Leila. I think there's a huge responsibility on all of us in higher income countries to reduce global inequity in this disease. And what can we do to help you? You're doing amazing work, but I do think there's a responsibility on all of us who can to help you.
Okay, so this is my opportunity now. Okay, you can help us by support us in our work during advocate work. For example, now we are unable to reach the rural community. Only we have done this advocate session in regional hospitals, major 5 regional referral hospitals where blood cancer patients are referred to. But we are unable to reach the local communities, the lower health centers where patients often go when they see the early symptoms of the CLL, and they are being transferred from one health centers to another. So I think by helping us to put more emphasis and reach more community, the wider community, the rural communities, it will be perfect. And also, yeah, by training, support our research, because other countries, I think they are very lucky. I heard today about many clinical trials that are going on, but in lower and middle income countries, I promise you, there isn't. So and we have many scientists, we have them. For example, I work at the Muhimbili University, at our department of hematology. There are many scientists, but we cannot afford to conduct these clinical trials. So if you can support us in our researches, the training, yes, you could.
Very good. Do we have another? I see at the very back a question.
No problem. Okay, with 2 mics, yeah.
Hello, hola a todos.
I'm going to translate from Spanish to English. He would like to share his experience as a patient advocate in Argentina.
Bueno, he tomado nota de algunas cosas. Realmente agradecemos mucho la invitación y todo lo que aprendimos hoy acá.
He would like to thank you for the invitation. He's been learning a lot from this Congress.
Hemos escuchado sobre calidad de vida, herramientas.
We've been listening about quality of life, all the tools that we need.
Empatía, diálogo, demás cuestiones que hacen a la calidad de vida de los pacientes.
Empathy and dialogue that make patient quality of life better.
Pero bueno, una de las problemáticas que tenemos nosotros desde nuestras asociaciones,
One of the problems that we got in our association,
nosotros no podemos estar hablando hoy de calidad de vida y aspectos emocionales si todavía no tenemos resuelto el tema de acceso a los controles y a los tratamientos.
we cannot talk about quality of life because we haven't got any access to any treatment, any drugs. So how can we talk about quality of life in patients that they don't have the opportunity to get any treatment?
En muchos de nuestros países que integran Latinoamérica, más de 40 países y 650 millones de habitantes.
In a country, in the Latin American countries with 40,
Más de 40 países
more than 40 countries
y 650 millones de habitantes.
and 650 millions of inhabitants.
Todavía estamos tratando de resolver el tema de los accesos.
We are still trying to solve the access to medication.
Los pacientes se siguen muriendo
Patients still dying
sin poder acceder a tratamientos ni a controles.
without having access to treatment and controls.
La diferencia estructural que tenemos entre la lucha desde estos lugares hacia la problemática que tenemos nosotros en Latinoamérica es muy diferente.
So many different, all the themes that we are treating here and in our countries.
Nosotros necesitamos el compromiso de la red y la visibilización también de cómo nos pueden ayudar desde su lugar contemplando la red de CLL para poder visibilizar la problemática que tenemos nosotros en Latinoamérica.
We need the help of CLL of how to give visibility to all the problems that we got in Latin America.
Necesitamos generar acciones en común.
We need to generate common actions,
Y dar los pasos para que los pacientes puedan acceder desde nuestros lugares y nosotros como asociaciones de pacientes podamos darle este tipo de herramientas que son muy buenas, pero bueno, hoy la problemática es tan diferente desde nuestra mirada que no podemos anticiparnos ni poder darle todas estas herramientas si hoy no podemos darle acceso a su tratamiento. Los pacientes se están muriendo.
It's not very easy to, our patients are dying. For that reason, we need to, if you could help us from the association to help them, to try to give them the proper treatment. So somehow, you know, somebody was asking, how can we help, you know, to the hematologist in the middle, I forgot your name. How can, you know, CLL can help? Well, they could help us, you know, just trying to visibilize, you know, how Latin America, the condition of Latin America, that they haven't got no access.
Nosotros necesitamos que se hagan políticas globales
We need to have global politics
para poder dar solución a esta problemática,
to give solution to these problems.
porque realmente un mundo mejor lo vamos a hacer entre todos.
Because a better world, it could be made by everybody.
Y
With the help of everybody.
esperamos que estas reuniones puedan salir nuevas herramientas y contamos con el apoyo de CLL, porque realmente la situación en Latinoamérica es muy compleja.
Sorry. We hope that from these meetings, we could get the tools and the help, because the situation in Latin America is very complicated.
Y esperamos que nuestra voz sea escuchada y le quiero agradecer a todos por escucharnos.
I hope that our voice can be heard and to appreciate all this, you know, the invitation.
Gracias.
Thank you.
Thank you. Thank you very much. Thank you very much for taking your time to come and join us in this way today. It's a very stirring message, and it just shows there's so much work to do on that global scene. Thank you once again. Is there one last question?
Can I throw a question? And I think it's adding on just because of what that gentleman had said. And it's always a question of what we can do to help. And John, I was actually going to bring you into it, and I see that you've taken the microphone, is that I'm wondering, like with the CLL Advocates Network, the IWCLL, because last year we had some doctors from South America really passionate and telling us that we need to up our advocacy and up the engagement with the political establishments and all. So I'm wondering, with IWCLL, CLL Advocates Network, the Max Foundation, what can we do to help? Have you any ideas?
So thank you. And the Max Foundation was one of the initiatives that I was going to speak to. So Anna Shu in particular, through the IWCLL, had negotiated with, and to date the major success has been with Beijing, to provide zanubrutinib that is then available for distribution at no cost through the Max Foundation into those countries where there are sufficient diagnostic processes to ensure that these drugs are reaching the patient groups that are required. That structure and that mechanism is still in place, so I would certainly encourage those advocates in countries where, in that instance, covalent BTK inhibitors are not currently available, through their national networks to approach the Max Foundation and see what procedural and structural requirements are necessary to engage with that distribution capacity.
I think I nearly knew you were going to answer, and that's why I came up. I wanted to try and bring that into it. So anyone else have any questions? Or? Okay. You're trying to make me lose weight, you know.
I'll meet you halfway. My name is Kathy. I'm the Regionate for Africa Middle East with the Max Foundation, and I'm so happy about this agreement we've signed and the partnership, and that our name is coming up so often within this community, which means we're already part of what the great work that has been happening. But as much as we as an organization want to support and want to do more, we need partnerships like this and with industry and with anybody else that wants to become involved to join us in this mission. Because there is so much we can do. We were just discussing with CML, we're currently supporting 19,000 patients here, active, on treatment today. But with CLL, we're still in the starting phase, and we have so much more to do. So we do need support. And if you want to advocate or become involved or talk to donors or stakeholders or whoever that is, join that and refer them to us so that we can do this together. Thank you.
Thank you, Kathy. That worked out well, did it not?
Not even planned.
Not even planned, that's right.